Chondroblastoma occurring in the epiphysis of the lower end of the femur on your left hand. Chondroblastoma occurring in the epiphysis of the lower end of the femur on your left hand side and the right hand side epiphyseal area of the humerus. As I said earlier, 30% of them show calcification. Again, I insist, if you want to demonstrate calcification, please do a CT. Otherwise, in plain films, calcification is so minute, it may not be shown. Chondromyxoid fibroma, an aggressive lesion, metaphyseal, eccentric, difficult to diagnose. Histological proof is absolutely necessary. Diametaphyseal, and then expanding lytic aggressive lesion. As I said earlier, ABC, aneurysmal bone cyst, is the differential diagnosis. If on CT or MRI, if you find fluid levels, then you are sure there is an aneurysmal bone cyst. In this lesion, again to describe, eccentric, expanding, transition zone is thin, so it must be benign. Few examples of chondromyxoid fibroma, one in the proximal portion of the right humerus and another in the calcaneum. Again, how can you differentiate from chondroblastoma, for example? The calcaneal lesion, biopsy is necessary. And then we come to the fibrous lesions. All of them may not be tumors. Fibrocartical defects, non-ossifying fibroma, I showed you an example. Ossifying fibroma, which is common in the tibial shaft. Fibromyxoma, cortical desmoid, desmoplastic fibroma, chondromyxoid fibroma, and in children, you can get fibromatosis, both osseous and soft tissue. Common fibrocartical defects around the knee, whether in the tibia or in the shaft of the femur. Again, Caffey has described these lesions, and as the child grows, these will disappear. Some of them, which we call bone island, they may be really well-healed or over-healed fibrocartical defects. Non-ossifying fibroma, cortically oriented. Look at the sclerosis surrounding the margin. That means healing is entering into the lesion. Some of the lytic lesions in the center also shows sclerosis. Classical of non-ossifying fibroma. You can't think of chondromyxoid fibroma. It's not aggressive. Again, healing non-ossifying fibroma, metadiaphyseal, ill-defined border, sclerotic rim, low signal on T2 if you want to really do an MRI, which is not indicated at all, and histologically all bundles of spindle-shaped cells. But then again, biopsy is no. Please do not interfere with this lesion spontaneously or with a minor trauma or with a fracture. They will heal up. Another, which I showed you earlier, and then healing type of non-ossifying fibroma. Look at the filling up of the lucency by newborn formation. Cortical desmoid, difficult to diagnose. Could be aneurysmal bone cyst. You don't really see the entire shell. Aneurysmal bone cyst can occur in the cortical bone, but you don't see the entire shell. And there are no bubbles or calcifications. So cortical desmoid. Infantile fibromatosis, which I didn't include in the classification earlier, recurrent soft tissue masses, infants. And if they are big, there may be pressure defect on bones. They do not calcify. Whereas juvenile epineuritic fibroma, soft tissue masses may be seen, and occasionally they may calcify. Ossifying fibroma, this entity you have to know, because often earlier, even today, they are described as what? Fibrous dysplasia. This is not fibrous dysplasia. This is really ossifying fibroma. How can you tell? It occurs in children. 10 years, 8 years, 11 years. In 5 years we have seen. Even 3 years we have seen. Occurs in the shaft. Expands. Benign nature. Occasionally pathological fractures may be seen. Trabeculated. And classical of ossifying fibroma. They may heal spontaneously, biopsy is not generally necessary, but age is important. Supposing the same lesion is seen, say, 12 years, 13 years, teenager, 25 years, then you think of fibrous dysplasia. And if it is around 30 years, if they have got satellite lesions, you can think of adamantinoma. So, depending upon the age, think of ossifying fibroma. Campanacci describes this as osteofibrous dysplasia. But whatever it is, the ossifying fibroma. And then the next age group is fibrous dysplasia. And next age group is adamantinoma. Again, look at this. Nature is an adult. All the epiphyses are fused. Adamantinoma. Expansile lesion. Lot of ground glass appearance. Calcifications are seen. And then one on your right side, multiple cortical defects. These are called satellite lesions. Proved to be radiologically diagnosed. You can think of it. You can suggest a diagnosis. But then pathological proof is absolutely necessary. Adamantinoma, bones subsistent to skin, not only in the tibia, occasionally you can get in fibula, and rarely in radius also or ulna. Tibia common, 90% of the time, tibia is common. Third, fourth and fifth decades. Look at the age group. Multiple, sharply defined, circumscribed lesions, lucent areas of varying sizes, sclerotic bone interspersed, and satellite lesions is a typical feature of adamantinoma. This entity is again a bugbear to me, desmoplastic fibroma. Again, Jaffe has described. So there must be histologically proved cases. 1958. Expanding lytic lesion, not an aneurysmal bone cyst, well-defined sclerotic border, irregular cortical margins, associated soft tissue mass. These are some of the features. One in the fibula, another in the iliac bone. Ladies and gentlemen, there is no way of radiologically diagnosing. But then, by eliminating process, is it an aneurysmal bone cyst? Is it a giant cell tumor? Is it an ossifying fibroma? Like that, you eliminate and then come to your conclusion. And then ask for a biopsy or a FNS. Fibromyxoma or fibroxanthoma, these are typical lesions. You don't need a biopsy. Generally occurs in the proximal ends of the femur or pelvic bone, and dense sclerotic bone with few trabeculae. Dense rind suggests it may be a fibrous dysplastic lesion, but this is fibromyxoma. Benign again. Lipoma, it could occur in the soft tissues. It could be periosteal, it could be intraosseous, and hemangiolipomas are very common in the vertebral bodies. Soft tissue lipoma in the elbow. Look at the lucency and thick capsule, dense capsule. Lipoma of the shoulder. All these are fat necrosis because there was a lipomatic swelling and we got massage thinking, it will disappear. But ultimately fat necrosis and several calcifications, spheroidal type of calcifications. This we have seen already, lipoma of the calcaneum, typical example with central calcification. Periosteal, look at the radiograph. Look at the lipomatous tissue with a capsule, but then cortical hyperostosis, periosteal reaction. Femur, tibia, and humerus are common bones, slow-growing soft tissue mass, lobulated fat with cartilage, and because of the cartilage, it calcifies, and bony proliferation, periosteal reaction is present. Calcification and lucency are the classical example of diagnostic feature of periosteal lipoma. Again, periosteal, calcification and ossification, but the lucency gives a clue that it must be lipomatous tissue. Again, lipomatous tissue, increased calcification and ossification. Periosteal lipoma in the thumb, soft tissue, it's a little dense, but still, if you look into the right side picture, there is central lucency. Again, these occur more than 35 years age, non-tender, and generally they don't get into malignancy. Fixed to bone, local hyperostosis is seen, and then Jacobs, he described it extensively, periosteal lipoma, lipoma with hyperostosis in clinical radiology in 1972. Vascular lesions, hemangioma common, cavernous hemangioma, capillary, venous, glomus tumor, hemangiopericytoma, various histological components. Hemangioma is soft tissues with calcified fibrosis. The bone may be atrophied or hypertrophied. Again, fibula, hemangioma, small fibrosis we have seen, soft tissue, and then the rib. Look at the trabeculae. If the same thing if you see in, say in the skull bones, you call it spoke wheel type of appearance, trabeculae, big trabeculae in the rib. And in the humerus, only a small lesion, and it's a sclerotic border. Actually, it is a benign lesion. Do not touch my lesion. It could be a small lipoma also. It could be just a benign cyst, just keeping it there for years. Hemangiopericytoma, again a difficult diagnosis. How can you tell? It looks aggressive, moth-eaten, permeative lesion, sometimes bubbles, periosteal break. You can't really tell. It's a histological diagnosis. Sometimes they say those lucencies oval, you should think of hemangiomatous lesions because they are cavernous and vascular spaces. Now, once you think it is a hemangioma, an aggressive hemangioma, think of a hemangiopericytoma also. Again, a large lytic lesion, expanding the bone. But if you look carefully, there are vascular channels going through the lesion. That suggests hemangioma, frankly. And there may be some fibrosis also. Ladies and gentlemen, it was given as a quiz to me at RSNA. And of course, I didn't ask for a CT or MRI or anything, or even an angiogram. I straight away said hemangioma, and they accepted it. Again, hemangioma of the scapula, difficult to diagnose. We took a biopsy, and it proved to be a bony hemangioma. Difficult to diagnose radiologically. Certain things are typical, but certain things are borderline. Vertebral hemangioma, jail bar type of appearance in the lucencies, classical. Hemangioma of the skull is a huge aggressive type of hemangioma. Some people thought it is a meningioma, underlying meningioma. Some people thought it is a Cooley's anemia, but the entire parietal bone is not involved. Speculated benign nature. What is the difference diagnosis? In anemias you can get hemangioma commonly, meningioma, and occasionally infection, particularly fungal infections with thick spicules. Small hemangioma in the skull bone, supraorbital region, spoke wheel type of appearance, the sclerotic border, typical. And synovial hemangioma with multiple calcified fibrosis all over. If the fibrosis is present, think of a hemangioma. But then please differentiate between fibrosis and a nugget-like calcification cartilage or an arc-like calcification cartilaginous lesion. That's important. Glomus tumors of phalanx, because it is in the distal phalanx, very painful, soft tissue swelling, throbbing pain, typical of a glomus tumor. It is benign. Now we will come to tumors of unknown origin. One of them is giant cell tumors, eccentric, lytic, expansile, remodeling of bone. Sclerosis is rather uncommon. Conspicuous trabeculae, so-called subbubble periums, no periosteal reaction. It may cross the joint also. Typical. Giant cell tumor, so expansile and aggressive, there is a aneurysmal bone cyst pattern also. Amongst giant cell tumors, 30% of them may have aneurysmal bone cyst component. This we have seen already, arising from the apophysis. Please remember that. Giant cell tumor of the phalanx, expansile, lytic, subbubble appearance. And now we have got giant cell containing lesions. For example, benign chondroblastoma. You will take a biopsy, there may be multiple giant cell cells. Brown tumor, often if it is a small brown tumor somewhere eccentric in the scapula or a clavicle, they think it is a giant cell tumor, biopsy, find giant cells. But if you look into the systemic nature, it is hyperparathyroidism with a solitary brown tumor. Multicentric giant cell tumors can occur in the same limb often. giant cell containing osteosarcoma, giant cell containing Paget disease. Paget disease, a complication of giant cell tumors, particularly in the facial bones and the skull bones. What is the differential diagnosis of giant cell tumor? It is just purely theoretical. When you look into the picture, the differential diagnosis depends upon the type of lesion, type of bones, age, etc. Bone cyst, simple bone cyst, aneurysmal bone cyst, bone abscess, chondroblastoma, enchondroma, hemangioma, where there are no trabeculae, purely cavernous, chondromyxoid fibroma, fibrous dysplasia, lytic type of fibrous dysplasia. And now we come to tumoral lesions. What type of simulating tumors? Simple bone cyst, aneurysmal bone cyst, fibrous dysplasia, pseudotumor hemophilia, pseudotumor of gout, ganglion, brown tumor, infective lesions like Brody's abscess or cystic type of tuberculosis. All of these come into differential diagnosis in tumoral lesions. Solitary unicameral bone cyst. Again, Jaffe and Lichtenstein, they have described new lesions like anything about 30 and odd. 1942, long bone, diametaphyseal, 80% occur in either proximal end of the humerus or proximal end of femur. Longitudinal expansion as opposed to horizontal expansion of the aneurysmal bone cyst. Fractures occur in 65% of the cases. That's how the patients come. Fallen fragment sign. Fracture occurs in the cortex, small fragments falls into the cystic area, it floats. You can detect it or demonstrate it by taking various views in horizontal position, vertical position, etc. Stroll, S et al., they have described extensively about solitary bone cyst, and in skeletal radiology also you can find the references. Simple bone cyst with a fracture, both are humerus. Here it is almost migrating into the diaphysis. Fracture, again there is a fallen fragment sign in both. If you can demonstrate that, it's typical. Rare sites of simple cysts, iliac bone and calcaneum. Calcaneum lucea lipoma, but here there is no calcification. And then the lucency, there is a haziness. It is not that lucent. Of course, radiologically you can't tell unless you take CT and measure Hounsfield units. But relatively you can tell by the eyesight. Aneurysmal bone cyst, you have seen an osteoblastoma earlier. This is very aggressive. And mostly it is aneurysmal bone cyst. We don't know what the underlying lesion is. Maybe osteoblastoma, but there's not much of new bone formation. Aneurysmal bone cyst. Another aneurysmal bone cyst in the vertebra, expanding, lytic lesion. Giant cell tumors also can occur, but they are more or less uncommon. You can find giant cell tumors, mostly in the sacrum. Another ABC, they don't go all the way to the articular margin. Classical example, bubbly appearance in the metaphyseal region. In the flat bone, scapula, aneurysmal bone cyst expanding, borders are sclerotic, thin zone of transition. Aneurysmal bone cyst may be associated with giant cell tumor, chondroblastoma, chondromyxoid fibroma, fibrous dysplasia, osteoblastoma, malignant tumors like Ewing sarcoma, and telangiectatic osteosarcoma. But fortunately today, CT and MRI help us by showing fluid levels. Not all aneurysmal bone cysts show fluid levels. Some of them are solid, although it is called bone cyst. Some of them are, stroma is very solid, fibrostroma. Hemophilic pseudotumor, unless you know the history, there is a male, generally, and then he has got hemophilia, recurrent bleeds into the iliac bone, producing valves appearance, sclerotic circles. Now histiocytosis, Langerhans histiocytosis. A child comes with a lytic lesion, say in the pelvic bones, iliac bones, multiple lytic areas. Benign nature, these are not metastases, they are not multiple, benign nature, not multiple myeloma because it is a child. And then benign natures, transitional zone, one we may find in the femur also. Think of Langerhans histiocytosis. 50-year-old woman, painful hip. What will be the differential diagnosis? Could be giant cell tumor, she is 50. It is not quite aggressive, it is benign. Could be metastasis. But that sclerotic border, negates metastasis. Multiple myeloma is not multiple, it is single. It is not expansile. So even at this age, think of eosinophil granuloma or histiocytosis X. It proved to be histiocytosis. This needed proof because we never know, early metastasis could be. Classical epidermal cyst in the distal phalanx, dorsal aspect expanding. That is important because epidermal cysts classically appear in the dorsal aspect, throwing the nail out, etc. No calcification. Brown tumor almost looks like expansile tumor, malignant or benign. It doesn't go all the way to the articular end to think of a giant cell tumor, brown tumor of hyperparathyroidism. And then some infective lesions which are rare, but still see YARS. From a tribal area I got this film, tertiary stage, gamma. In syphilitic gamma also you may find the same thing. Expansile, lytic, mostly sclerotic. That is important. And then one on your right side, actinomicosis. History is this young man was bitten by his wife from the saliva, that actinomicosis organism, not necessarily a fungus, it is supposed to be a bacteria today. And you can think it is infective lesion, periosteal reaction is there. It is not an eccentric soft tissue swelling to think of a tumor. It is bilateral soft tissue swelling and a lytic lesion with cortical thickening, chronic actinomycotic lesion. And so far we have mentioned about the conventional imaging, conventional radiography. More or less we have diagnosed about 80% of the lesions, and then we depended upon the rest of the lesions on pathology. Now, instead of going to pathology, intermediate between conventional radiology and the pathological diagnosis, advanced imaging methods help at least in 10% of the cases. Not only in diagnosing, not only in detecting, but to know the extent of the lesion, to know the aggressive nature of the lesion, to know whether the vessels are involved, to know whether the nerves are involved, whether the joint is involved. So, CT, MRI, radionuclide scan, and occasionally angiography. Angiography today we don't do much. Again, coming back to benign tumors, ethmoid osteoma, just osteoma, benign osteoma, CT. This is the nature of the tumor, dense. Why did we take CT? To just know how much of the globe or how much of the eyeball is involved, etc. Textbooks describe target sign. Even on a plain radiography, you can see the target. A large lucent area with a sclerotic bone, spicule. And the vertebral lamina, look at the nice lucent area and the spicular bone, classical of osteoblastoma. On a plain film, you may miss it on a vertebral body. All you may see is dense sclerotic lesion. Again, osteoblastoma, it is bigger than osteoblastoma, large lytic area in the lamina of thoracic vertebra with irregular matrix. Only the CT has helped us to make a firm diagnosis. Again, common in the femur, cortical type of osteoblastoma. Do you really need CT or bone scan, isotope bone scan? I don't know. It all depends upon the level of confidence on the part of the radiologist. If you have seen many, definitely you can diagnose just on plain films alone, it is osteoblastoma. The nidus is there. The abundant sclerosis of the cortical bone, cortical hyperostosis. And then if you take CT, you can see the nidus. And if you take a isotope study, you can see the hot spot at that area. MRI studies also help. 28-year-old male with history of blunt injury to right chest wall 4 years ago, and then comes recently increasing in size and pain. Possibility on plain film itself you can diagnose osteochondroma or enchondroma, but is it undergoing malignancy because she is having pain? Localized view, you can see it is a chondromatous lesion, no doubt. CT, again chondromatous lesion, no soft tissue swelling, no calcification extending to soft tissue swelling. So we said it is benign enchondroma. That satisfies the patient as well as the clinician who has referred the case. That's where CT plays a role. Again, the same case. MRI. It is on plain film, you know, it is a lipoma of the thigh. Do you really need an MRI? Not really, but to show the nature of the high signal intensity of the nature, MRI is taken, there is no malignancy. Sometimes liposarcoma can also occur. Skull. Earlier I showed you spoke wheel appearance, and if it is not obvious, then take a CT, spoke wheel appearance of the skull bone hemangioma. This, years ago I have seen at Osmania Hospital, 22 years old boy, comes with painful index finger. It is soft, compressible soft tissue swelling. And then the permeative appearance and the vascular nature, we thought possibility of hemangioma. And then I injected into the vein in the dorsal of the wrist, and lo and behold, it's a venous type of hemangioma. You see multiple vessels going into it. So that's how the angiography helped to confirm. Occasionally, hemangioma of the vertebra, you will do angiogram with CT and MRI, we don't do it anymore. Classical case of hemangioma, just to show the CT appearance. Note the polka dot they describe. The vertical bars end on seen as polka dots. Another case, sometimes not just polka dots, cavernous spaces you can see. Look at the enlarged pedicle on a conventional radiograph of the spine. Cavernous hemangioma. Again, a focal hemangioma showing the polka dot appearance on CT. Aneurysmal bone cyst. A CT appearance, expansile, elytic, sclerotic borders. The translucent zone is small. And what are the MRI appearance of hemangioma? Only after the advent of MRI, earlier we used to call it hemangioma. Now we know that there is a lipomatous element in the hemangioma. Sometimes they are benign. Often it is benign, also benign nature, not so aggressive. Sometimes they may extend into the spinal cord and produce extensive pressure. Often seen in females. Most of the time they are incidental in